Good afternoon, ladies and gentlemen. My name is Nirav Shah, the director of the State of Maine Center for Disease Control and Prevention. I'm joined by Commissioner Heather Johnson from DECD. We're here today, Thursday, May 14th, to provide everyone with a statewide COVID-19 update. And we unfortunately begin today's update yet again on a sad and somber note. Maine CDC is reporting the passing of 3 individuals with COVID-19. One was a man in his 60s from Penobscot County. Another was a woman in her 90s from Cumberland County. And the third was a man in his 80s from Cumberland County. As we've discussed too many times now, each of these numbers was a person. A person who now has left behind family and friends, and those families and friends who today join 66 other families and friends in Maine who grieve the loss of those loved ones. As always, all of us here wish those family members and friends our deepest condolences during this time of their grief. May the memories of their loved ones be a blessing to us always. Overall, Maine CDC is now reporting 1,565 cases of COVID-19 across the state, representing an increase of 50 cases since yesterday. Of those cases, 1,405 are laboratory confirmed and 160 are probable cases. Overall, there are now 207 individuals who have been hospitalized at some point, an increase of 3 since yesterday. And 37 individuals remain currently hospitalized. That's a decrease of 4 since yesterday. Of those 37, 18 are in intensive care and 7 are on ventilators. The number of individuals on ventilators remains the same as it was yesterday. As I mentioned a moment ago, sadly, there have been 69 individuals now who have passed away and 958 who have recovered, representing an increase of 15 recoveries. In terms of the critical assets that Maine CDC tracks on a daily basis, there are currently 361 ICU beds, 163 of which are available. There are 313 conventional ventilators, 230 of which are available, and there remain 416 alternative ventilators across the state. I'd like today to provide an update on some of the outbreaks that we've been working with and tracking across long-term care facilities across the state. At the Edgewood Rehabilitation Center, there remain a total of 19 cases of COVID-19. At Falmouth by the Sea, there remain 66 cases of COVID-19. At the Hope House, not a long-term care facility, but a congregate care setting, there are 22 cases. At the Maine Veterans Home in Scarborough, there remain a total of 55 cases. At the Oxford Shelter and some of their associated facilities, there are cumulatively 14 cases. At the Springbrook Center, there have been a total of 35 cases. And at the Cedars of Portland, a total of 17 cases. Again, these are cumulative cases, and I'm just offering that as an update to give everyone a sense of where things stand. Another healthcare facility, a facility that was not on that list, reached itself an epidemiological milestone yesterday. The Augusta Center for Health and Rehabilitation has now gone 15 days since a new case of COVID-19 was recorded either among a staff member or a resident. That's more than the standard incubation period, which is a positive sign. We continue to work with that facility to make sure that they have everything they need to prevent ongoing infections of COVID-19. And we, of course, wish all of the residents there great health, and we hope to see that trend continue. I'd like next to provide an update on some of our overall public health preparedness activities. The first is on the fit testing front. As we've talked about, we've been working closely with our colleagues at the National Guard to conduct fit testing for healthcare workers so that those workers can utilize N95 masks. Just yesterday alone, our colleagues at the National Guard fit tested 114 staff members. Today, just today alone, those same men and women at the National Guard will have fit tested 112 staff members at facilities across the state, in South Portland, in Sanford, and in Yarmouth. Cumulatively, by the end of the day today, the men and women of the National Guard will have fit tested 660 individuals, and they still have about 500 more to go. I again would like to take this opportunity to thank the men and women of the Guard for joining up with us to get as many healthcare workers across the state fit tested as possible. We continue our work to distribute personal protective equipment across the state. Just today alone, our team, working in concert with the Department of Transportation, is pushing out 106,000 pieces of PPE to facilities and locations across the state. The bulk of the deliveries today are actually cloth face coverings. However, overall, we have continued to work to push out other types of personal protective equipment to healthcare facilities statewide. And thus far, by the end of today, we will have fulfilled about 1,624 orders for PPE across the state. Finally, before I close, I wanted to just provide one piece of clarification on some news that I shared yesterday around vaccinations. As I noted yesterday, nationwide as well as in the state of Maine, the orders for vaccinations and the distribution of vaccinations to VFC providers have fallen significantly compared to 1 year ago. I just wanted to clarify and discuss that just a bit more. The data that I shared were for distributed vaccines, vaccines that providers ordered and Maine CDC sent to the practice group. In addition, it did not represent all pediatrics and family practice groups across Maine, but rather just those who are enrolled in and serve as providers for our Vaccines for Children program, which is a program that provides no-cost vaccinations for children across the state. Overall, that represents about 350 providers. Over the next several months, over the next 2 months, Maine CDC's immunization program will be conducting surveys to get a better sense of the actual immunization rates. But based on the concerning signal we saw in the data, that there were significant drops in the number of vaccines that were delivered, I just wanted to clarify that it won't be for several more weeks before we are able to match that with data on the actual number of vaccines that were administered and whether there was a corresponding drop in those. That's a data point. What I really wanted to underscore was that this time, now more than ever, is a reminder of the importance of making sure that each of us takes steps to make sure we're not getting behind on routine medical care, such as vaccinations. But the same advice applies to anyone who might be grappling with, say, a chronic disease. So if you've got asthma, diabetes, hypertension, heart disease, even though we are in a time of COVID-19, healthcare providers across Maine remain able to provide you care for those chronic conditions as well. As we talk more and more about reopening, and as Commissioner Johnson has joined us today, as we talk more and more about returning to those recurring rhythms of everyday life, we want everyone to be in optimal health as we start getting back together for play dates and family barbecues. Even though so much around us has been put on pause because of COVID-19, necessary routine health care need not be one of those things. So with that, I'd like to turn things over to Commissioner Johnson.
Great. Thank you, Dr. Shah. Earlier today, the Mills administration, our administration, announced that effective immediately, Maine lodging providers can begin accepting reservations for stays with an arrival date of June 1st and beyond. Reservations can be accepted in line with Maine's restarting the economy plan. The details of that are on our website. But in June, start with Maine residents and people who have already done their 14-day quarantine period. The previous executive order prohibited such reservations. This change comes amid collaboration with the tourist and hospitality sectors and the partnership that we are developing to be able to look forward to our summer. You know, we're pleased to take this next step forward to start down a path of solutions, including potentially testing, other protocols to keep Maine residents safe, tourists safe, and our economy healthy. So with that, I think we can go right to questions. Dr.
Great,
Shah.
great. Thanks, Commissioner. We will turn things over to our colleagues from the media. And today's first question goes to Charlie from the BDN.
Yes, hi, Dr. Shah. Thank you. I guess the first question has to do with Durgan Pines Nursing Home in Kittery, which, unlike Cedar Ridge Center in Skowhegan, there was a case, a resident there who tested positive for the coronavirus, and apparently the CDC did not agree to conduct sort of widespread testing of staff and residents there. Can you explain what the difference was and what happened at Durgan Pines versus what happened at Cedar Ridge?
Sure. Thanks for raising that question, Charlie. I'm glad you brought that up. Charlie asks about the way that we approach testing at long-term care facilities. And Charlie, let me say at the outset, especially to all of those nursing home operators and facility operators who are who may be watching right now. We at Maine CDC work on the basis of guidelines, but no guideline is an inflexible rule. We stand ready to work with each and every nursing home operator or medical director when they call us. We want to always try to be looking for solutions to challenging situations. We don't just live and die by guidelines. We are always standing by to have a conversation. And those operators can reach out to me. They can reach out to one of our medical epidemiologists. They can reach out to one of our infectious disease epidemiologists. We are always standing by to help them think through difficult situations. Now, Charlie, you raise a good question about how we think about these situations as they unfold. And I think your question really highlights how fact-intensive each of these situations is. For example, in the Cedar Ridge facility in Skowhegan, we were made aware of two individuals, one who had tested positive and a very, very close contact of that individual who was also symptomatic. But there was also something really important going on at the Cedar Ridge facility, which was the outbreak of another infectious disease, an infectious disease that can have symptoms that closely mimic the early phases of COVID-19. As a result of that, from an epidemiological picture, the signals that we were getting from the data we were seeing, we couldn't be sure whether they were attributable to COVID-19 or a situation that could be caused by the underlying outbreak that we were already aware of. On top of that, the facility itself was ready, willing, and able to conduct the swabbing and the testing, the swabbing, and send those over to our laboratory. But the critical difference is that there was a facility in Skowhegan where there was an already ongoing outbreak of another infectious disease, which makes it a different epidemiological picture. We needed to have clarity about what we were seeing and whether it was COVID-related or related to the other infectious disease that was already ongoing. If you contrast that with Durgan Pines, where there was a patient who had just arrived, who had already tested positive. Now, in that situation, although I don't believe any of our medical epidemiologists or I was not contacted, the critical difference there is that it's not so much whether to conduct universal testing, but when to conduct universal testing. And a person who's just arrived in a facility, if we conduct universal testing facility-wide as we've talked about in these meetings, how we interpret those results is difficult because it takes a little while for the virus to develop and show signs and symptoms in people that can be detected by the laboratory test. So the real question is not whether to test everybody, it's when to test everybody. And that's really the set of critical differences that explain why we go in one direction in one facility and another in a different one. It's not that we have rigid rules. We ask operators to give us a call, to touch base with us, to get on the phone with our medical experts, our infectious disease experts, because no two outbreaks are the same. Or to put it differently, when you've seen one outbreak, what you've seen is one outbreak. And you've always got to dig into the facts because that really does drive the differences. Does that answer your question, Charlie?
Well, can you say anything more, though, I guess about why Maine CDC wouldn't at least help the facility, Durgan Pines, test the people who had been exposed in this case?
I believe, well, I'll double check, but let me be clear. Anyone who was showing symptoms or was a close contact of anyone in an institution would have met our criteria for testing.
And then just sort of so given what happened at Durgan Pines and what you know, what do you think would have been, or what is the appropriate time frame to sort of test the people there, do you think?
It really does depend on the situation. And that's why we really ask facilities to reach out to our medical epidemiologists and infectious disease experts, rather than just say, for example, calling the lab. The epidemiology of these facilities is critically important. Medical directors, facility operators, we strongly urge them to get in touch with us because we want to work with them. And because these differences are important. If all of the individuals who were exposed were in a small room, that's one thing. But if, for example, someone was masked the entire time and there were no other close contacts or exposures, that's a different situation. The facts really govern how we make decisions in any public health situation. There's not a one-size-fits-all approach. But I think the key is that these differences, for example, the fact that there was already an ongoing outbreak at another facility, those drive us to make sure we have as many facts as possible. And again, we ask every medical director, every facility operator to reach out to our epidemiologists and infectious disease specialists to make sure they're touching base with us. I'm going to turn next to Pat Callahan over at News Center.
Yes, Dr. Shah, thank you. I'm wondering, we've heard cases, I actually have two questions, if I may. There have been in New York State as many as 100 children, and now in Massachusetts, in Boston, as many as half dozen children who are being treated for what doctors are calling pediatric multisystem inflammatory syndrome, which they believe may be linked to the coronavirus. Have we seen any cases in Maine of that yet?
So Pat asks about a concerning signal that has been seen in some other states involving the interplay of COVID-19 in children. And Pat, we are ourselves deeply concerned about this development and the science. We are not aware of any such cases in the state of Maine. Last week and then through the weekend, I had the opportunity to talk with and speak with my counterpart in New York, who himself happens to be a pediatric cardiologist by training and is very knowledgeable about these issues. I reached out to him because I wanted to make sure that I was up to speed. I was sufficiently concerned by what my counterpart shared with me, so much so that first thing on Monday, we issued an emergency health alert to every single physician and healthcare provider across the state, alerting them to the latest data given what was known at the time. We also, in that alert, made this condition mandatorily reportable to the Maine CDC so that if any cases were to arise, physicians would know to report it and how to report it to us. Thus far, we have not received any reports, but our antenna are up for it. If those phenomena start happening, if we start seeing reports, we've got the architecture in place to respond to those. But we remain concerned about this.
Thank you. Second, I'm wondering if you could update us on the status of hiring people to do contact tracing. And I'm also curious as to whether any of those people who are doing that work now run into resistance from those who might be reluctant to share personal details or just worry that someone's scamming them, because that's what we hear about all the time.
Yep. So, Pat, I'm going to take those in reverse order. Your first question's a really good one about the success, the interactions that our contact tracers have had when we reach out to individuals. And contact tracing is really one of the bread and butter pieces of public health epidemiology overall. It's not new to Maine CDC. We've done it for every single infectious disease out there, or most infectious diseases out there. And we've already been doing it for COVID-19 since day one. What we find generally in infectious disease situations, especially in outbreaks, what we find is that when folks get a call from Maine CDC, they're usually almost always willing to work with us. Now, folks might, for example, express some skepticism about who it is that's calling us. That's okay. All we ask them to do is to hang up and call the Maine CDC's main number, and they'll be transferred right back to that same person. And that's fine. But what we've typically found, especially in outbreak situations, is that folks are responsive, they want to share their data, they want to share their story. And that really does accord with, at the national level, according to the director of the US CDC, what the nationwide experience has been, not just with COVID-19, but with other diseases as well. In terms of our hiring, we're continuing to ramp up. Our plan is to go in phases. As the number of cases increases, partly because the amount of testing is increasing, we will continue to ramp up our own hiring. The overall goal is, at the very highest, to hire approximately 100 individuals, but that is neither a floor nor a ceiling. If we need more than that, we'll continue hiring up. If the numbers change such that we don't need so many, then we don't need to go in that direction. But it's an ongoing process. Every couple of days, we're bringing on new individuals from across the community. I'm going to turn, you bet, Pat. I'm going to turn over to Kara DeRose at the Maine Beacon.
Thank you. I actually had a question or two about contact tracing as well. You might have already answered this a little bit, but I was actually kind of wondering, how many people do we have currently doing the contact tracing? Mm-hmm. And how many people at a given time can they, do that tracing for?
Sure.
And how much has this capacity potentially increased over the last few weeks?
Great. So in terms of the overall contact tracing numbers, there are roughly 30 individuals at Maine CDC who are conducting contact tracing. Again, our hope is that if needed, we can more than triple that. We can even go beyond that if the situation requires it. The number of individuals that one person can contact trace, as it were, really depends on where the patient is in their course of COVID-19. The first phone call usually takes about an hour, because that's when we go through everyone's movements, where they've been, who they've been in touch with, get those individuals' contact information. But after that, the calls usually entail a quick check-in. How are you doing today? Do you have any symptoms? Things of that nature. And then we continue to check in with individuals on an ongoing basis. And if all goes well, at those last set of calls, the discussion is whether they have met the US CDC's criteria for being designated as recovered. And that's how we get to the numbers of individuals who are recovered. There's a major IT piece on this as well. And we're making some pretty significant changes on the back end to make sure that our IT system gets us and helps us track all of the data on a real-time basis as we want to track. So there's some significant changes going on that front. I hope to have a lot more to discuss about that in the next 24 hours. I'm going to turn now over to Amy Brown over at WERU.
Thank you, Dr. Shah. Dr. Fazeli from the Durgan Pines facility in Kittery says that the patient that tested positive had been screened prior to coming into their facility and then tested again several days later, had tested negative both times, but after developing a low-grade fever several days later, they tested that resident again and the person tested positive. So they decided to test some of the other residents and staff who were exposed. And their issue doesn't seem to be with the actual testing, more with the processing of the test. They said they contacted Nordic, which declined to do the processing of the test because they said they don't test contacts. And they referred them to the CDC and were referred back to Nordex who finally decided to do it, but their complaint seems to be that they don't believe that there are clear guidelines if they try to be proactive and do testing on their own in these congregate care facilities of who they should send the test to be processed. And he claims that he requested those and was told that they are confidential. Can you comment on that? And I have a follow-up question.
Well, I have not heard from that gentleman. I've spoken with our medical epidemiologists, our infectious disease specialists. I don't believe that he's reached out to them, but we are happy to discuss that with him. Again, we stand ready to work with each and every facility. You know, I would welcome an opportunity to discuss all of this. But we've been pretty clear, I think. Our guidelines are on the CDC website. There is nothing confidential about that. I'm not aware of any member of my staff telling him that anything with respect to testing is confidential. It's publicly on our website, so there's no reason why anyone would have indicated to him that anything that we're talking about here is confidential. We are, of course, hoping very quickly to move in a different direction and be able to test much, much, much more widely. But right now, as it stands, if there's an individual who has exposed others and those others are symptomatic, they would meet the criteria for testing, not just the Maine CDC criteria, but the criteria from the Infectious Disease Society of America as well. So this is all the more reason why we really ask facility operators to reach out to us, to set up a call with one of our medical epidemiologists or infectious disease doctors, because the facts really do matter. You also noted as well, Amy, that an individual can test negative and then test positive. All the more reason why it's not so much who we test, but when we test as well. And those facts are really critical. Those are discussions that we would absolutely welcome having.
Thank you. And on a different note, you reported on Monday on 3 different group home outbreaks. Any new cases with those, and can you confirm whether there were any children testing positive as part of those outbreaks?
So there are no new outbreaks or no new cases reported in any of those facilities. And given the small size of those facilities, for privacy reasons, we're not commenting on the ages of any of the cases in those facilities. They are quite small, and in order to protect the privacy, potentially the privacy of children in this case, the potential privacy of children, to the extent any of them we're not commenting on the ages.
Thank you.
I would like to turn things over to either Steve Missler or Patty White from Maine Public.
It's me again. So I have it's almost the same question as yesterday when we had 38, an increase of 38 cases, and today we have 50. I'm just trying to get a sense of have you been able to deduce anything that might be to help explain what this increase might be? I think you just said that you might be testing more as of now, and maybe that's why more cases are being revealed. And if that's the case, could you tell us how many tests were done on Tuesday versus yesterday?
Right. So, Steve, we've been discussing that same issue internally, as you can imagine. Our overall positivity rate has remained about where it has been. So some of it is a function of not necessarily new outbreaks, but more testing that's being done, and thus more cases that were being discovered. Of the cases that I'm reporting today, the increase of 50, the bulk of them appear, again, these are cases that are being investigated as we speak. But as to the cases from yesterday, as well as to the cases from today, a large fraction of them appear to be either close contacts of existing cases or, alternately, in counties where community transmission has been documented. We are still at those 4 counties where community transmission has been known to occur. And the bulk of the growth in cases continues to be in those counties. That's another way of saying, for those of you who are in counties where community transmission is occurring, it's really occurring. It is out there. And a lot of the cases that we are seeing are partly in individuals who are close household contacts, but also from individuals who have just been out and about in different ways and may have contracted COVID-19 in their community. Again, we don't have any new outbreaks to report today. And as I noted from the cases in the existing outbreak, Steve, not significantly increased numbers even there. So the other sources in these situations are existing contacts of close cases as well as overall community transmission. I'd be remiss if I didn't, again, underscore the importance of staying inside if you don't need to be outside, continuing to wear face coverings to prevent you from unknowingly transmitting COVID-19 to others. The disease is most definitely out there, and as you see from the case counts, continues to increase.
And just a quick follow-up. Do you have numbers of tests that were performed Tuesday and yesterday? And then I have a quick question for Commissioner Johnson.
Sure. I don't have the daily test from Tuesday or today with me here today. We generally tabulate those on an ongoing basis, typically weekly, sometimes more occasionally than that, but typically on a weekly basis. The numbers we look at on a daily basis are things like hospitalizations, ventilator usage, ICU bed admissions. But I'll see if we can dig those numbers up. But I can't promise that, Steve.
Okay.
Yep.
And for Commissioner Johnson, I just have a question about this change, which I guess doesn't technically affect the 14-day quarantine, but it continues to raise questions about how one would even know if somebody booking a room come June 1st has satisfied that requirement. Who is in charge of checking that? Is it the hotel? Do they just say, have you quarantined for 14 days? In Maine, which is, I'm not sure how one would even do that, frankly. Do they come to Maine and pull over on the side of the road? And then I honestly don't know. It just doesn't, I'm trying to figure out how it would work in practice.
Yeah, so Steve, thanks for the question. Certainly the 14-day quarantine as it relates to tourism has created a lot of discussion. It is not kind of maybe necessarily the ideal solution. What it is right now is the current solution and really the only solution available from a public health perspective to implement at this moment. As you know, we are actively working with industry partners, with some private sector folks to try to figure out other solutions. This isn't likely to be a one solution answer. It's likely to be multi-layers of protocols, changes in behavior, changes in activity, potentially capacity changes, as well as some science support. So I think there will be a lot of pieces that we are putting together and working on right now. So back to your original question, what we believe to be true is that there are a lot of people who have second homes in Maine and have been here for a period of time, and they may want to travel like other Maine people will in the month of June, and we want to make that available to them and not limit them because they've been here past the 14-day quarantine period, and so we believe their travel in our state would be safe.
I see. So it's designed to help people who may have summer homes here who may want a vacation away from their summer home within the state is what you're saying. But that still raises some questions about whether somebody from outside of the state just wants to have a regular old vacation in here and how that would be even checked if they do comply with that 14-day quarantine.
Yeah, the quarantine at this point is a self-test, right? We know people want to be safe and want to keep people around them safe, and so we're relying on that right now. Certainly, there may be other options as we go forward, but right now, the only way to track a quarantine is for people to self-identify.
Right, so an honor system, basically.
Yes.
Great. Thanks, Steve. We're going to turn now to Brian Sullivan over at WABI.
Thank you, Dr. Shah. Two questions for you. You just touched on a little bit with positivity rates and the increase in testing capacity. Do you think that eventually, with more tests being done, you will switch to releasing the testing, the positivity rates in the state and reporting those each day?
We may. The question for us is, of all the data that we track, which are the ones that will change our approach on a daily basis? Positivity rates are something that we like to look at about once a week. The things that really change our approaches on a more daily basis are things like healthcare utilization, case counts, the number at outbreaks, things of that nature. So we may move toward going in that direction. We haven't made any final decision. Every piece of data that we release has to be thoroughly vetted by an epidemiologist. And so the question for us is, what are the most critical pieces of data on a day-to-day basis that we need to release that will affect policy, that will affect our response? As testing numbers go up, depending on what we see and how the outbreak and the nature of it changes, we may move toward releasing it more often. But I want to be clear. It's not that we're not releasing it. It's just, when is it optimum to calculate it? Calculating it requires an immense amount of time. It's not simply turning on the computer and pressing a button and having the numbers being spit out. If it were that easy, we'd update it every hour. But it actually requires a full-time epidemiologist to compile a very high number of labs that are reporting into us and take a look at each and every one of those to make sure there's not duplicate results for different patients, things of that nature. So we absolutely want to do the work because we need to keep tabs on the positivity rate. But as we've seen, the way it affects our policy is something that's a little bit more slow going than, say, the number of ICU beds. If we were to see a significant spike in the number of individuals, say, on a ventilator over a 24-hour period, that's something we would immediately want to jump in and investigate before anything else. So we're open and interested in releasing and calculating data on a more occasional basis. But right now, it really is a question of what are the pieces of data that affect and alter policy.
And can you give me a little clarity about the Hope House in Bangor? Were there 2 new cases there today? Am my math wrong on that? And can you just talk to us a little bit about the tracking of data for as much as you can in that specific location? Yep. So at Hope House, what we've been undertaking there is a continued effort to identify contacts and identify close contacts of confirmed cases. Kind of to the point we were discussing earlier, when we identify someone as a close contact of a confirmed case, we'd like to make sure they get tested. So as we've identified more and more close contacts of confirmed cases, we have had an uptick of I think you're right, 1. I don't think it's been 2. I think it's 1 additional case. And that's been over the past now about 2 weeks. So we're continuing that work. Our epidemiologists are continuing to talk to people who have come into contact with people, and we draw an ever-widening circle around each case to try to see if anyone in their orbit may have tested positive, may have had symptoms or would need a test. When we identify those people, depending on the proximity of their contact, then we try to get them tested, much as we talked about with the Durgan Pine situation. I'm going to turn next to Michael Fern over at the Maine Edge.
Hi, Dr. Shah. I saw a statistic a few days ago that 11% of all U.S. cases were in long-term care settings, but contribute to about a third of all U.S. fatalities. In doing the math, our stats seem higher here at around 19 and 50%. Why are our ratios that much higher?
The bottom line answer is because we're much more aggressive with respect to universal testing. We move toward testing universally in a facility when we detect either the probability of transmission, or usually that's defined by an outbreak. Many other states still don't yet move toward universal testing, even in outbreak situations. Indeed, as you noted with the Cedars facility, Cedar Ridge, we even moved to test there because we were concerned about 2 simultaneous outbreaks co-occurring. So the bottom line answer is that we test much more aggressively in long-term care facilities than many other states do, and have been doing so well before other states have moved toward it. I think I just saw over the weekend another state, I believe New York, is just now moving toward a policy that Maine has had in place for some time now. No, it wasn't New York, it was another state. But that's one of the main reasons.
Sure. And I had a second question for Commissioner Johnson. A few weeks back, someone had said that businesses who can work remotely should be able to do so, or continue to do so during stage 2. Are there ramifications if a company ignores that recommendation during stage 2 and returns to their offices? Thanks.
So, Michael, thank you for the question. Certainly, it's our intent that if people are operating successfully remotely, we would encourage them to continue to do that. We are open and flexible, as we have been throughout the course of this entire restart plan, to talking with businesses that feel like maybe they need to come back into their offices at an earlier time for specific reasons. So I think we are open to those discussions in the situations where that's necessary.
Great. Thanks, Michael. We will turn now to Brad Rogers over at WGME.
Okay, thanks very much. I have a question for each of you. First, Commissioner Johnson, I was having a little hard time hearing you initially. If you could stay a little closer to the microphone. But are you saying that hotels in every county can take reservations for June 1st and beyond?
Yes, Brad, I apologize. Hotels in every county can take reservations for June 1st and beyond, again, following the guidelines under the restart plan. So there are some limitations about reservations for June and who those reservations can be for.
Okay, thanks so much. And why the change, I guess, is what I'd like to know. Why did we move it up from July 1st to June 1st? What was behind that?
So hotels were able to be open June 1st for Maine residents or people who have already quarantined in Maine. That's been a longstanding part of the plan. I think there was, as we continue to work with the industry, there was clarity around reservations and the criticality of having reservations for the future. And so this is just a step for us forward to, again, having that safe and successful summer that we are all looking to do.
Okay, thanks very much. And
Yep.
Dr. Shah, Maine is one of 8 states. Maine is one of 8 states where the numbers went up over the last week. I think you've explained why that is a little bit, but what needs to be done to get those numbers to start going down again? What more can we do?
Yeah, Brad asks about the increase of numbers that we've seen across the state, and what does that tell us about whether we need to be doing more? So, Brad, I think you're correct. One of the reasons for the increased numbers is the significant increase in testing that has occurred. As we go online at our state laboratory next week with our own expanded testing, more than tripling our capacity, there is a possibility that the rates will continue to rise. But Brad, one note there, there have been cases that have been going up across the country. There aren't really that many states where the numbers are going down. It really depends on the rate at which they're going up. And I think what we're seeing in Maine is that because we're testing more and more opportunities for testing are being made available or being recommended, for example, in individuals who are in shelters for people experiencing homelessness, situations like that. As we broaden that circle, we are likely to see more and more cases. What that tells us is a couple of things. The first is that looking under the rocks for more cases is a good thing, not a bad thing. The second thing is that it tells us is that we might be at a level where we're talking less and less about a surge, but rather a plateau. A high plateau, to be sure. A plateau doesn't mean that things are getting better. It means that things are staying the same at a rate that might not be very desirable to us. And the final thing that I think it points toward is really the necessity of making sure that the public health recommendations that Maine CDC, that the US CDC have recommended are really abided by. These are recommendations that involve everything from staying indoors when you don't need to be outside, wearing a face covering, and I think for me, and speaking on a personal note, one of the things that's most important is making sure that vulnerable individuals, be they older individuals or folks with chronic health conditions, try to maintain physical distance as much as possible, whether that entails staying inside or keeping a safe distance from others while they're outside. But to be sure, Brad, the increase of cases that we've seen over the past days is concerning. Partly it's a function of expanded testing, so in that respect it's anticipated, but it remains concerning all the same.
Okay, thanks.
Yep. I'm going to turn now over to Megan at WMTW.
Thank you for taking my question. This is actually for both Dr. Shah and Commissioner Johnson. So I was wondering if you could provide any more detail from your respective viewpoints on the guidance to businesses in regard to contact tracing. So what the CDC expects from them, from businesses, and how that data is incorporated into what we report and what we see, and maybe the guidance for these businesses. What in fact is it in regard to reporting, especially now since out-of-state visitors may be coming to vacation. This, I think, becomes, largely important. So can you each speak to that from your respective viewpoints?
Yeah, sure. So as we continue to update checklist guidance for business sectors, some of them include contact tracing elements, right? If you're in a restaurant right now, the restaurant will ask for your name, your first name of one member of the party, and contact information, either a phone number or an email address. They are keeping that on file in the event that they need to reach out to you, as Dr. Shah talks about kind of finding these circles and the expanding circles. The speed at which we can reach people is critically important. And so what we are asking businesses is to be part of this solution. And so that's why you'll see that on the checklist for businesses.
And as Commissioner Johnson noted, from a public health perspective, that information can be critical for us. If we happen to determine that a number of cases happen to be, for example, at the same establishment or at the same time, and report being in the same room together, we want to make sure we not only trace that information, but then contact others. The other piece of the contact tracing is that contact. So we would, in that situation, perhaps ask the restaurant to give us the first names and phone numbers of the folks who were there so that we can call them and say, hey, by the way, it turns out that you were at a particular establishment 12 days ago, and we've determined that there were some other people there who have now tested positive for COVID-19. We want to provide you this information and ask you if you'd be willing to share the names of other people who you were dining with so that we can call them and make sure that they know to stay on alert for symptoms. And we would want to do that with everyone who was in the facility at that time. The faster we can do that, the more effectively we can try to get people that necessary warning so they can stay safe. The alternative is going to the facility and, for example, to the establishment and, for example, asking them for every single credit card receipt from a 6-hour window, and then trying to find phone numbers associated with all of those, a process that could take days. And every day matters when we're trying to prevent individuals from spreading or getting too ill. That's why having that information for us, it gives us a major leg up in the event there were an outbreak.
And the information we're asking for is significantly less than a normal reservation would take,
exactly,
or any of that. It's a first name and a point of contact for one person for the party.
And it's not proactively reported.
That's right.
There's not a centralized database of all of these. It's only in the event that an outbreak or a case was traced to a particular establishment that we would then ask the owner or the proprietor to share that with us. I'm going to turn, the last question for the afternoon goes to Kevin Miller at the Press-Herald.
Great, thank you very much. So Dr. Shah, two questions, one for you, Dr. Shah, and then one for Commissioner Johnson. Dr. Shah, there's a report out today about a study from, I think, NYU epidemiologists that are raising some concerns about the number of false test results from the rapid return testing system by Abbott. What's Maine's experience been so far with the Abbott testing system, and can you update us on how widely that system is being used here in the state?
You got it. So Kevin asks about some research that has just come out from some colleagues, epidemiologists at NYU, that have continued to try to assess the scientific or the clinical accuracy of one of the rapid tests that we use. It's a rapid test called the ID Now platform. So Kevin, let me say a couple of things. The first is, as we've discussed at these very briefings for, gosh, I went back to my notes to look at the first time we talked about this concern. It was well over a month ago. So we've been aware of these concerns, first generated by some laboratories across the United States, one in Chicago, another in France, so across the world. And what they found was that a positive result from this device is one you can take to the bank. A positive result is a positive. But a negative result has some difficulties in interpretation. And we were aware of these actually even before we started distributing the machines. So what we did was make sure that every single institution that got one of the machines was aware of these concerns that my team of epidemiologists had. And we communicated with them that if you get a positive, you can take that to the bank. But if you get a negative and you still think that patient has COVID-19, right? They've got all the signs, they've got all the symptoms, but for some reason the test came back as negative, we want you to do two things. The first is treat them as if they were a positive. Give them the information on quarantine, isolation, staying safe, wearing face coverings. The second thing is to take a nasal sample and send it to Maine CDC. And we'll do a confirmatory test in the event that you're not sure about the positive. So that's the next thing we did. Third thing we did was we ourselves are running our own study or scientific analysis of what the experience with the machine has been in Maine. So we're taking samples that have come back negative and then running them at our laboratory in Augusta to see what the overall percentages are. That work is still ongoing. We still haven't received a sufficient scientific number to meet the various clinical criteria or the various scientific criteria for validity. But when we do, we'll certainly be sharing that information. But we wanted to see for ourselves what the experience has been in Maine with the accuracy of the test. Now, that all sounds perhaps a bit dire, but the fact is there is no such thing as a perfect test. There is no test out there that has 0 false positives and 0 false negatives. All tests have some degree of accuracy trade-off. And that's why the experience of skilled clinicians in knowing when a case could actually still be COVID-19, despite what the test says, is really important to us. Those clinicians can always and have called Maine CDC on numerous occasions saying, you know, I just ran this test on this patient and I'm not sure if I believe it. What do you folks think? And we talk that through with them. That's not just for COVID-19, that's for any clinical situation. That's what our infectious disease epidemiologists and our infectious disease doctors do all day long. Kevin, you asked about the distribution. The machines have been distributed. We are are being distributed. We're in the process of sort of redistributing some of them to make sure they're focused on areas that we are going to be concerned about going forward. For just one example, I actually spoke yesterday with the CEO of Cary Medical Center because we're planning for the summer and the possibility of arrival of farm workers. And so we want to make sure that we've got sufficient testing capacity to accommodate that possibility. So we're looking at moving one of the machines up to Caribou. So that's kind of a sense. It's a fluid situation based on the way that the dynamics of the outbreak are changing. Does that answer your question, Kevin?
Yeah, it does. Thank you very much.
Great.
And for Commissioner Johnson, just a quick question. We continue to hear confusion from people about where they should go to report concerns about either businesses that are not following the health and safety guidelines, or maybe they're not enforcing, the guidelines on their customers. Some people are saying they are telling us they should call the police. Others are calling their town offices, and then others are saying they should be calling you. So where should people be going with their concerns if they raised it with the manager and they are not getting a response? And do you have a team that's large enough to look into these sorts of complaints?
So Kevin, thank you. Actually, earlier today we've started a broader discussion around that and enforcement and really trying to track down steps. Certainly, we want to start at step one, which is education and why are we doing some of these things? How do you do them effectively? How do we all work together on compliance? So that's kind of step one and really where our focus is. Certainly, there are going to be situations at times that we're going to have to move past that into maybe more traditional enforcement. So there will be a process for that, but for now, Kevin, I think the best place is people can report them into our department, or if they have a licensing department that they were already be working with, they can certainly report them there. But if they report them to business.answers@maine.gov, we'll take those, we'll get them into the queue to be contacted and work the situation from there.
Great. Thanks, Kevin. I just want to close on one note, which is just a request out there for folks who are watching who are administrators at hospitals, nursing homes, other long-term care facilities, any type of group home. All of us that are working on coronavirus across the state stand ready to work with each and every one of you. Although we try to have guidelines in place, they are just that. They're guidelines. Flexibility in an outbreak is always key, and every situation is different. Every situation is fact-specific, fact-intensive, and based on those facts, may call for a conclusion that's different from what the guidelines say. So we stand ready to work with each and every facility operator, manager, administrator, because every situation is different. Again, in outbreaks, when you've seen one outbreak, what you've seen is just one outbreak, and every facility is different. Although we do typically recommend moving toward universal testing when there is an outbreak, that's not always the case. And when situations are different, when epidemiological criteria recommend or suggest a different outcome, we'll be the first ones to move in that direction. But we are standing by to make sure that everyone has an open line of communication with us, because we absolutely want to provide the quickest, most accurate scientific guidance to everybody out there. So with that, Commissioner Johnson, anything on your end?
Just one more logistical cleanup, if I could. So the department today has posted a number of new checklists in preparation for stage 2, which is tentatively scheduled for June 1st. The remainder of the guidance for stage 2, which would be June 1st, will be posted by mid next week on May 20th. So if you don't see your guidance yet, it will be posted by May 20th, but there is new guidance posted today if anybody's looking for it.
Great, great, very good. Well, thank you so much all for joining us. We look forward to chatting again soon. Take care.
Thank you.